question. They thought maybe she has scleroderma and pulmonary hypertension. And she was worked up with pulmonary hypertension, which is her dominant clinical abnormality, with usual things that one sees, like a perfusion scan. So you can see here's a perfusion scan. There are no segmental or even subsegmental defects. This goes back quite a ways, as you can tell. And there's the lung ventilation. But her clinical state over time has deteriorated, and they've treated her with all kinds of cocktails for pulmonary arterial hypertension over time. And eventually she came to lung transplantation for that. So let me bring up some images. So this is from 2018. And let's see if I have better images. Actually, let me bring this one up because that was from the VQ scan. So we have a small profusion, quite small, of septal lines in the lung apices then. Peribronchial fluid cuffs, yes. So we have mild interstitial lung edema and small pleural effusions. Let me go back up here, and I'm just going to leave this image here at this level, and I'm going to bring up a comparison one from later on. And of course it moved. So we have a couple of years between these two. On the follow-up ones, I do not see findings of interstitial edema, but this is viewing the lungs in the usual display setting. And the way I report lungs that look like this is as a diffuse pulmonary hyperattenuation abnormality, just top to bottom. Now, these are ground glass opacities, but they've become confluent, but it's still very abnormal. Perhaps over here, one can see that these are centrilobular ground glass attenuating nodules. But of course, when the process is diffuse, this is what one might see. So let's go to the most recent before. Let me just get my timing right. Okay, that is the one, the more recent ones. This is October 2021. And this one is March of this year. Sorry about that. I'll make this big. So again, standard window display setting. And if you look at the background, there is a diffuse pulmonary hyperattenuation abnormality from top to bottom. And that's really the pertinent observation. I don't see signs of interstitial lung edema here or pleural fluid, but still very abnormal over time. So I'll leave that there and bring in the, and I'll fix that up. Images, I'll make this big. So here we have explanted lungs. What I think is producing the diffuse pulmonary hyperattenuation abnormality is this diffuse expansion of the interalveolar septa by obviously cells, but not inflammatory cells. These are red blood cells, but otherwise the interlobular septa are diffusely expanded. And let me go on now. Here is, at least on one interlobular septum that was described as edematous. Here again, you can see the diffuse expansion of the parenchymal interstitium, as well as foci pulmonary hemorrhage. And then the key findings here on the elastin stain are findings of PVOD. In fact, there's some vessels like this, the lumens of which are completely obliterated by fibrous and connective tissue. And the veins have just one elastic lamina. And then the CD4 stain for endothelial cells. Sorry about that. I don't know what I did there. Oh, geez. Let's see if I can fix that up. What did I do? I don't even know what I did.
Suppose you
to do that.
close it and reopen it.
Yeah, let me close it. It's crazy. Yeah, let me fix that up. It confirms that this is a capillary proliferation that has expanded the interstitium of the lungs, so capillary hemangiomatosis. So basically PVOD, now of course the PVOD is not producing the opacities, but it's the diffuse expansion of the interalveolar septa that's producing the diffuse lung opacities. And I think most pathologists nowadays believe that the primary insult is the PVOD and the capillary hemangiomatosis is an epiphenomenon or a secondary phenomenon consequent on the PVOD. So a really nice rad-path correlation, I think.
That's really cool. You have the pathology on that one.
Yeah.
I think the other thing too, Howard, on the imaging, you know, the left atrium was certainly normal, if not small.
It's good.
Which, you know, is usually the case here, just because you know, this is a pulmonary venous issue. You know, and the left heart should be, you know, should be normal. I mean, that left atrium is normal, certainly not big.
Sometimes we see mildly and even moderately enlarged lymph nodes in this condition, but not in this particular person. I don't see that.
And I think we've discussed before, I don't know, I don't think they're ever proven, but I would guess it's just congestion, right? Like veno-lymphatic congestion, like you see with edematous lymph nodes.
Within the lymph nodes?
Yeah,
I mean, or the capillary hemangiomatosis?
Within the lymph nodes.
Oh, I see. Yeah, if you go to Google and you kind of just type in PVOD or PCH and lymph nodes, you can find an article in which, at least one I found, that described the pathology within the lymph nodes in this situation, and the pathology is all over the place. They describe all kinds of stuff in lymph nodes, and I don't know what to make of that. It's not just plain edema, so I don't know exactly how what happens. Okay. This is a nice, fun case for anatomy. So if you have no history at all, there are a couple of things that are just interesting. See if you see any interesting findings. There are 3 of them that relate to the mediastinum and mediastinal lung interfaces. I'll just give you a moment and then I'll show you what the items are. So here is one, azygos vein. Right here, above the aortic arch, this little mogul, left superior intercostal vein. And then this is kind of subtle, but you'll see in a moment it's real, that there is a left convex mediastinal lung interface here in that basal hemithorax. So I'll bring up the CT coronal and I'll just make it a kind of a slab. It's kind of nice to look at. And we have contrast medium in, or we'll have one with contrast. Let me just get the right one. Let's see. Don't have contrast there. Okay. Nope, there's another one I want to show you. Here we go. So here we have the azygos vein. This down here turns out to be this very distended hemiazygous vein crosses the midline. Here you can see the superior intercostal vein communicating with hemiazygous, accessory hemiazygous crossing the midline. So basically venous collaterals, and there are a whole bunch of them. So in this particular person, there is a finding like really subtle on the lateral projection that explains the etiology potentially of the central venous obstruction and collateral vessels. And I'll just bring up the sagittal because it's really subtle. If I can find it again, which is kind of weird. Let me just make this this.
Yeah, the coronal CT, you could see the wimpy little kidneys too when you were going through.
Yep. Oh, that's really weird. Anyhow, let me make this go away for a moment. It turns out that it's really subtle, but I'll try and bring it out. But there's a rugged Jersey spine. There is too much bone, and there are just beneath the superior and inferior end plates, a rugged Jersey spine of renal osteodystrophy. And of course, the most likely explanation, given what we see of the SVC down here, is long-term catheterization and subclavian vein stenosis. So a nice example of just those 3 bumps that represent collateral pathways for blood flow to the atrium. So kind of a nice teaching case for residents for anatomy. Here's a really nice case of, let me bring this on up like this. I'm not going to show this to you in order, but I'm going to show you just for fun kind of a before and after, if I can get things correct here. Okay, before and after. So in looking at the pulmonary vessels, I'm going to draw your attention to the caliber of the pulmonary vessels before in the right lung compared to the left. And yes, there are a few opacities here that turn out to be consistent with small infarcts, but notice that this artery is really skimpy, whereas after a procedure, it is open again. No surprise that during the workup that we have this degree of perfusion difference between the 2 lungs. And here we have a really nice image of CTEPH, but dramatic, kind of unilateral, like that. So a lot of abnormality, no perfusion, and findings consistent with a dramatic CTEPH case, dominantly on the right side. There were a couple of small webs here on the left side. So this is before and after surgical endarterectomy. And at least imaging-wise, they got a nice result after they operated on this patient. So look how nicely they opened up the vessel, going out here, and even further down a bit, right down there and beyond, right there. Lots of bronchial collaterals, obviously, as well. So a really nice case of CTEPH. I think this person's relatively young, as in 31. Kind of a strange case.
Howard, this isn't the case that you shared
No.
a couple of weeks ago
No.
with.
This is a different one. I came across this one subsequently.
Got
The
it.
case that I sent out, I'm waiting for the repeat CTA so that I can compare it with the one done in December of 2021 to try and figure that case out. But this one, one of my colleagues showed me, but this is a different one. Okay, Jeff, those are mine for now.
All righty, thanks. Who'd like to go next?
I'm happy to go whenever.
All right. There you go.
All right, you should see my database screen.
Yep.
Okay. I've shown a couple of these. This one just came in this week. This is a 43-year-old who came into the ED with chest pain. And this is not a normal aorta for a 43-year-old. I hate this finding on radiographs because most of the time it's mediastinal fat or it's just tortuosity of the aorta. But if somebody has chest pain, you have to worry about an acute aortic syndrome or at least an aneurysm. This guy did go to CT, and you will see on the CT there is some. Let me make this a little bit. These images are pretty thin, so let's average it up a little to make them a little bit. There we go, like 2.5 millimeter thickness. You can see there's some high attenuation blood, and along the ascending aorta as well. And I think there's a little bit along the pulmonary arteries in that shared adventitial sheath. And there's a little bit of pericardial effusion as well. And that effusion is intermediate attenuation. That on its own should get you thinking about intramural hematoma for sure, involving the ascending aorta. But this is another one of these sneaky little limited intimal tears right there in the ascending aorta, another Svensson type 3 lesion. So that's the extent of the dissection. It is a dissection. This was confirmed at surgery that it actually extends into the sinuses, and you couldn't really even see it down there, and to the point where they had to replace the valve. And I'll show you a coronal in a second because I think that really helps bring these out. But that is the extent of the defect in the aorta. And with these, it's interesting because you can see right there is the lesion. That this isn't just a true intramural hematoma because this is not like an intimomedial flap. This blood is extending out into the adventitia and then along the pulmonary artery and even leaking into the pericardium, as you saw. So these can be super sneaky, but this is a type A and went to surgery and was confirmed. So the last one I showed was from a couple of years ago, but these do creep in. And I think the Stanford paper said these were, somewhere around 20% of the cases that they reported in their series were similar to this. So
yeah, that's a kind of a high number. Interestingly, the ones that I've seen, either my own on occasion, the ones that you've shown, and even in articles, they always seem to involve the ascending aorta just close to the sinotubular junction, the sinuses of Valsalva. That's where you get this abnormality.
Yeah, I was showing this case to Costa, and he was saying that when they see these at WashU, because they've seen a few of these too, and he said they invariably are patients with some sort of aortopathy. This guy's only 43, and it's curious. I don't know why his coronaries are so large. I didn't look to see if he's chronically hypertensive, but his aorta's 4.4 or something in here. So certainly, is big. It's not 5 or 5.5 like you often see, but yeah, it's just this is all you have to see for it to be a dissection with the limited intimal tears. So these are easy to overlook.
Yeah, great example.
Now this is not easy to overlook. This is a case that was brought to my attention. One of the pulmonology fellows was reviewing this case. So this is several years ago. This patient presented, and you can see this huge thing occupying a portion of the mediastinum. And before we look at the lateral, it's interesting that there's not a lot of mass, or there's no mass effect on the trachea really, at least on the PA view. It's not displacing it either right or leftward. And you can kind of hallucinate an air fluid level here. You can even see on the thumbnail for that lateral view, but when I blow it up, you'll see that this is why. That this is all posterior to the trachea. And again, a little bit of, a little lucency there. Looks like some sort of air fluid level or interface in the retrotracheal space, so in the esophagus or near the esophagus. And let's see. So the CT was done at that time. And you can see why it looks like that. That's the dilated esophagus. And then this is a mass involving the esophagus. And it looks like you've got esophageal lumen here. It looks like it's either submucosal or intraluminal. So this patient was recommended for surgery. They were a little reluctant at the time because it sounds like their symptoms weren't too crazy, and they were told they were going to have an esophagectomy and whatnot. And they actually left AMA and then came back 2 years later, and it's still there and had gotten a little bit bigger. It looks the same essentially on the radiograph with that mass effect. The repeat CT that was done, you can see this mass is now maybe a little bit larger. So they did take, well, definitely larger inferiorly. So they took this out. And any guesses on histology?
Can you go, how does it go all the way down towards the G junction?
So it goes almost to the gastroesophageal or to the thoracic inlet, and then it kind of ends right here at the near the inferior pulmonary veins. And then the esophagus beyond that looks pretty normal. No nodes, no.
The air
no
in the
distant
esophageal
disease.
lumen right there? Yeah, it is, isn't it?
Yeah, yeah,
The air in the periphery of it.
yep. Right here,
Because I was
here.
wondering
That's all.
about it.
Is it an intramural duplication cyst or something?
It has some vascularity in it. You can see.
Is it one of those polyps?
Yeah,
the
huge.
fibrovascular polyps? That was a thought.
Yeah.
Yep.
Yeah, this is not a polyp. It was not a leiomyoma. This actually turned out to be an esophageal schwannoma.
Oh,
Gosh.
So,
gee, seriously.
I've seen, you see the schwannomas listed on the differential. I mean, obviously never this big, but yeah, that's what this turned out to be. I mean, clearly it wasn't going to be something, horrible like an adenocarcinoma or even a squamous cell because it was there for years. And then I'll follow up with this one. This is a patient who had esophageal cancer, and I don't even know. It was a distal esophageal cancer. I think this was post chemo, and all you can really see is there's a little bit of thickening at the GE junction. So they did some induction therapy before they did the esophagectomy. So this is day 1 post esophagectomy, and then let's see, this was the day they sent them out. They've got a small pneumothorax, and then where's the one? This is when, shoot, maybe I don't have the initial image. Well, anyway, they came back in. No, this is it. This is the one I saw earlier this week. So 2 weeks post-op, and now you can see the difference. When I called the surgical team to tell them what was going on, their first thought was this was bowel in the chest, and I was like, no, this is not bowel. This is all just atelectatic lung from this large pneumothorax here. So there's a small pleural effusion associated with it. So of course the suspicion was that there was some sort of leak, and this was a CT esophagram. And this one actually did turn out to show the finding. You can see here's the contrast in the lumen, and then just right of midline, that contrast is outside of the lumen at this anastomosis, right in here, and leaking into the right pleural space, and a little bit of contrast, hint of contrast layering there. And the entire lung is collapsed. There's a little bit of rotation of the mediastinum to the left, and their plan is to put a stent in to see if they can cover up the small leak rather than going back in with surgery. But the subsequent radiograph I showed you is post chest tube placement, and this thing has decreased in size the last couple of days. So getting better. And hopefully this will seal over, since it's hard to see the action. It's got to be right here next to the staple line, but
Yeah, exactly.
Little bit of leak, a little bit of drip there of contrast. So, and let's see, I'll save this one for next time since other people haven't gone.
All right, thanks, Travis. All right, let's see, Seth or David?
I have one quickie.
Alrighty, I'll give you control. There you go.
Okay, hope people can see a radiograph with a pacemaker and a TAVR. So kind of a looped in the right atrium course here of the cable going to the electrode here, which is out at the apex. Now that was 2015 at the time of placement, and the person now is more symptomatic. Let me show you a current radiograph that shows lung edema. Here is exhibit A, lung edema and pleural effusion, so it looks like worse heart failure, and we have the same positioning here of this electrode. So we got CT, and as part of the CT there was a scout view, and amazingly this thing ends up heading posteriorly, so looks just fine for right ventricular location of that electrode, but the lateral view shows it posterior. And let me show you on CT how this pacemaker wire got to the left ventricle. So here we have this ventricular lead here going through the right atrium into left atrium here, and then ends up going posteriorly here into the left ventricle. So I don't know, I mean to look this up, but I don't know whether the electrocardiograms with this pacemaker in place showed this, because you'd expect that there would be late depolarization of the right ventricle. So you'd probably have, you know, an early left ventricular pulse going away from you, and then you'd have, later on, you'd have, you know, an R wave here reflecting depolarization of the right ventricle because of the delay. And the sagittal view shows this. So this was not intentional. It was not placed into the left ventricle intentionally. It got there by perforating the septum. I don't think it went through, you know, a PFO or, you know, opened a PFO. It just probably perforated. And so here we see it going into the left atrium and then back into the back wall of the left ventricle. So this is a bit of a surprise, and there had been some spine CTs that actually showed this in the past, but people interpreting the spine CTs were not alert to pacemaker cable courses and lead courses and so forth. So it was not really recognized until this month, several years after it was placed. So have you guys seen this before? Have you seen inadvertent left ventricular pacing?
No.
Yes, it
No,
you know, some left ventricular leads didn't get there via the same route, but ended up in the left ventricle.
I think
Yeah,
I
no,
think Seth and I have both shown
Ventricular
cases
pacing.
that went through the aorta, right?
Yeah.
Yeah, and then, you know, space the left ventricle, these days people use the cardiac veins on the surface of the left ventricle. So this is, you know, inside the ventricle, it's not on the surface, outside.
Did it work?
Well, it was, the person was being paced for these 8 years. So yeah, it was working.
Oh, that was there 8 years?
Seriously?
This was put in in 2015.
No, that's hard to
So
believe.
did they think it was, did they think they were in the coronary sinus, or did they think they were in the right ventricle?
You know,
Can you scroll through it again real quick? I was trying to get my cases ready. Can you just, where is it going through? It's going through the septum?
yeah, it goes to the septum. So it's actually easier to see here on.
So it's going through a PFO?
Well, that's I would like your take on that. So
I mean, I have seen them go into the left atrium. Yeah, it is going through a PFO, right? Go up higher?
Well-
Sure looks like. I mean, unless, well, either a PFO or they created a little PFO. It's hard to tell.
it's right at one edge of where there seems to be a very thin, you know.
Yeah, it's a little anterior for where you would expect the actual, anyways, it's hard to tell, but that's, I don't think I've seen them accidentally go into the left atrium and pull back. I've never seen one actually go there, and it wasn't intentional.
It was
Like
not,
the-
no.
That's-
Okay, I'll check the old notes. I haven't had a chance to do that yet. to see whether people were aware that there was some anomaly in the way they looked on an EKG or something like that.
Because I have seen ones where they like the pulmonary, the coronary veins are sclerosed or something, they can't get it in. They do some weird things where they bury it somewhere that, and I've called them saying, and like, no, we did that purposely. But I doubt they, I mean, I doubt they did this purposely, but that's just so odd.
Well, and the other thing, I mean, this was done outside, so there's a lot of, difficulties in communication. This was placed in 2015, and the person has only become a patient here more recently. So I don't know what their thoughts were. I'll see if Epic is revealing on that regard.
And
Okay,
it
guys.
seems to be just a conventional dual chamber pacemaker lead setup for example, a bradycardia or something.
Well, the other electrode is in the right atrium. So, the usual intent is to pace the right atrium, hit it first, and then with an increased ventricular distension, then hit the ventricle slightly later. So they've got the atrium here, but they're pacing the other ventricle, which is going to result in a delay of function of the right ventricle.
Isn't that an ICD lead though in the LV?
No,
It's a conventional
pacer
pacing
lead.
lead.
it's a pacing lead, not a defibrillating lead.
Yeah, that's weird. That's just, they just somehow screwed up, but
Can you scroll up on it? The other.
I think the criterion for being admitted to a cardiology fellowship is that you be big and strong. And so, you push just a little bit if you're big and strong, and you can get it to go right through the septum. Piece of cake. There's also mitral annulus calcification here too, incidental finding.
I'll
Okay.
ask one cardiology guys here whether on conventional, if they do it conventional interrogation that they do, surveillance interrogation, there would be clues that the lead is in the LV rather than the RV, given the way they usually do lead interrogation post-procedure over time.
That'd be interesting. But I think that an EKG would show it too. But I'll check.
Yeah.
Okay, guys. Thank you.
All right, thanks, David.
Jeff, I have two very quick cases.
Sure.
Nothing really interesting this week. So this is a case where you can, I think, make the diagnosis from this one image. We can see that the liver is quite low signal on this SSFP image. Now, what's interesting here, so the spleen is gone. You can also see the pancreatic tail is very low signal as well. And, there's no really normal signal for the myocardium on an SSFP, but this is pretty dark for a standard SSFP imaging. And here is and people know that they were trying to look for hepatic iron overload. I think I have all the patient data removed from this, I do. And so we do T2 star maps, which are basically, you just look at the T2 star myocardium at different echo times. And obviously you lose signal as the T2 star gets longer because you get more involvement with homogeneity of the field because you don't have that refocusing pulse. Anyways, long story short, this is probably the worst case of myocardial iron deposition I've seen. You can see here we start at around 2 milliseconds, and honestly, we get to 6 milliseconds, we're already losing the vast majority of our signal, and then the myocardium is basically gone and dark by about 12 milliseconds. And so you just basically draw maps or contours, and it's variable, which, over 20 is always normal. I mean, most people who are normal are, 40, 30, 40, so on and so forth. There's an intermediate range depending on what you look at. Below 16 is always abnormal. Some people say below 20. I've not seen one down to 5. The other interesting thing is that, you can look at the liver. So the liver is the blue circle, and you can see that the T2 star is actually elevated, but that's only because there's no curve to the line, right? So normally things lose signal as the echo time increases, but because the liver is so infiltrated with iron to start and has thus no signal, that it can't form a curve. So it's literally a straight line. So the computer, you know, when you try to form the or get a slope of the curve for your T2 star calculation, it can't figure it out because basically there's no slope. So that's kind of interesting, and which you do see with some pretty bad iron overload cases. The thing I don't understand about this, and it kind of goes against what I've always been taught, is that since this is a case of sickler who's had multiple transfusions. Now, I don't understand. So first of all, getting hepatic hemochromatosis, liver myocardial iron deposition in someone with repeated transfusions is uncommon. And also, usually with people with repeated transfusions, you don't usually see the pancreas being dark. You know, I always remember pancreas is a primary iron storage disorder, and the spleen is the secondary. And if so, you have the spleen's dark and the liver's dark, is usually a secondary disorder, which this patient has because he's a sickler, versus a primary disorder, like someone who has an inborn error of metabolism that leads to iron deposition. So I'm a little confused as to why the sickler has such horrendous iron deposition in the myocardium and pancreas, but he does. I don't know if anyone has any insight on that.
So, Seth, I'm a little confused. Are you saying that people with multiple transfusions don't get a dense liver?
No, they do get a dense liver. They very rarely get myocardial involvement.
Got it.
So the myocardial involvement and the pancreatic involvement is really uncommon in transfusion-related iron deposition. So the liver, yes, liver, you see it all the time. It's just the myocardium and the pancreas are usually associated with primary disorders rather than a transfusion issue.
No, I don't.
Yeah. Anyways, this is the lowest T2 star I've personally seen.
How old is this person?
He's like 35.
I wonder if it's just the chronicity that finally got the iron into the myocardium, just that it's, been going on for decades.
Yeah, no, it must be. And he's had, countless transfusions.
Right.
But it just goes against the classic teaching of, because honestly, I think this may be the first transfusion related myocardial involvement I've ever seen. I have, other patients who have other causes that are primary, but nonetheless, it's there. And he's a little dilated, but his function is A-OK, which is super. This is a case where it was just a misread by some of us, and it's just an interesting case. So this patient was sent to us from the outside and did this not completely send over? No, it didn't come over. Anyways, you could see there's what looks like a PE up here. There's a PE, well, I don't know, it's not really a PE. There's something filling this pulmonary artery here, and there's some other areas where the pulmonary arteries are filled. But there's also this soft tissue that was called chronic thrombus encasing and knocking out the SVC, and then had these areas of kind of consolidation. There's also marked thickening of the peribronchovascular interstitium. If you look at it on soft tissue windows, you can see there's edema along that peribronchovascular interstitium. This was called CTEPH with infarcts. The nodules are really atypical you don't usually see, I think they question superimposed infection. I understand that. I think, let me show the follow-up because we should have all the images, hopefully. Maybe we don't. So this is the follow-up 3 weeks later or 4 weeks later. Here's that soft tissue now, and the CTEPH guys had asked me to take a look, and I'm like, ooh, that's not good. So now we have not only the stuff in the pulmonary arteries, but we got stuff all throughout the pericardium, which they subsequently put a drain in because the patient developed constrictive pericarditis. And so I said this is going to be some form of tumor. I didn't know what it was going to be. I said TB or tumor. Those are my two things if I see something this nasty. Lymphoma, I kind of thought of initially, but I don't know if I've seen a lymphoma knock out the SVC. But still, this turned out, it's unfortunate. This patient was pregnant. She's like 28 years old and she's pregnant, and they just did a biopsy through the pericardium because had to do she was in such bad constriction, and it was some very poorly differentiated sarcoma that literally just did horrible things. And so all this stuff I'm not 100% sure what all the nodules are from. I mean, the stuff in the pulmonary arteries is clearly going to be sarcoma invading from the SVC. I don't know if some of it is infarct. She wasn't acting infected. The initial thought was CTEPH with infection. She wasn't acting infected. And also, I'm not really sure to tell you the truth, what the pronounced thickening of the peribronchovascular interstitium was, because her pulmonary veins were patent on the right. So I'm not really sure why she has what looks like just really remarkable edema around the peribronchovascular interstitium with the septal thickening in the lower lobes. I don't know what's obstructing the flow there. Unless, I'm not really sure. But anyways, this was a case we just had, just a really bad sarcoma.
You said it was poorly differentiated, but if there was any angiosarcoma components, those could explain some of the funny lung things.
Yeah, no, that's a good comment. I'll have to look at the path. This case is, the imaging I think is from, this is the first one. I think the second imaging is from a couple days ago, and like 2 or 3 days ago, and I looked at it as this tumor, and I think they literally just did the biopsy yesterday, and the frozen was poorly differentiated sarcoma. But you're right, that's a good thought that this is just all probably angiosarc, given what the lung findings show.
Yeah, we had a case of metastasis. I mean, I think it was picked up on autopsy. It was just looked almost like organizing pneumonia or something, or infection.
Yeah, and just the progression in like literally 2 or 3 weeks was just shocking. I know that these do that, but it really was shocking to me. Anyways,
I showed an angiosarcoma about 2 months ago that rapidly progressed too, just over a couple of weeks. It was all over the place like this one.
Yeah, so I think they're going to try to, the sad thing about it is she's like very pregnant, and they're going to try to, they're not really sure what to do, but I think they're going to try to deliver the baby at some point, and it's not going to have a good outcome. But all right, Jeff, I'll let you.
That's a tough one. All right, I think everybody's going. Let's see, Shrav, do you have any cases?
I got 2.
All right, there you go.
Okay, can you see my screen?
Yes.
Okay, so it's not uncommon that as chest radiologists, we come across some lesions that are outside the lungs and mediastinum and heart. And so here we have this calcified mass. And when we see calcified masses in the soft tissues, always good to, assess the appearance of the calcifications. And so we see these, one thing to pay attention to is, is the calcification kind of starting peripherally and kind of going from peripheral to central, or is it kind of starting centrally and going kind of expanding out? And that helps that differentiate between things like myositis ossificans, where you have the peripheral calcification versus maybe something else that starts out with central calcification. It's also important to pay attention to the regional osseous structures to see if there's any like any periosteal reaction, cortical thickening, any cortical endosteal scalloping, anything that's abnormal in the adjacent osseous structures. And and of course, as radiologists, we should pay attention to any other findings that can clue us into the diagnosis. So I came across this case a couple of days ago, and came across this lesion, which kind of looks a little bit alarming at first. You kind of wonder, could this be some sort of malignant lesion? But then paying attention to the appearance of the calcifications, we see that they kind of look sort of lobular, and there are areas that are more confluent and dense. And so we've kind of excluded myositis ossificans because this doesn't start peripherally and progress centrally. So the question is this some sort of osteosarcoma or something else? One thing that you can see here is some asymmetric cortical thickening of the clavicle right here, but we also see this kind of lucent lesion here. So as to whether the clavicular cortical thickening is related or not, could be unrelated. This could be an osteoid osteoma with some cortical thickening. But the lung findings are really interesting in this patient. So we see these kind of basilar predominant centrilobular ground glass nodules. And if we take a look here at the abdominal CT, we see that there are pretty long segment calcifications of the left upper quadrant arteries down here. And as we come down, we also see atrophic kidneys, right lower quadrant transplant, and also one other thing that we see in the mediastinum are these hyperattenuating nodes. And so the diagnosis here most likely is tumoral calcinosis, as opposed to an osteosarcoma. Of course, at the time I recommended further imaging just to get the rest of the lesion, which is it's only partially imaged here on the CT, but just a nice appearance of something that could look malignant, but is most likely related to the patient's longstanding renal dysfunction.
Mhm.
And that's taking a look at the calcifications here, kind of keep in mind how that looks. And so let's compare that to a case of metastatic osteosarcoma where we have osteoid matrix mineralization. These are osteosarcoma metastases. And here we get this kind of more confluent, cloud-like, puffy-looking calcification with these ill-defined margins. And so this is a good case of osteosarcoma with METs. And here you can see some pulmonary metastases with osteoid matrix mineralization as well. So good appearance for that.
Very nice.
And that's I can give the screen back to you however that's done.
All right, I can just take it back. All right. Oh, it's gonna make me do this again. All right, I have to log out.
Radiology.
I have to log out and log back in. I'll be right back.